risk factors that increase your chance of developing dyskinesias over time with the use of L-DOPA. I'm going to tell you about those here in a second. But as far as managing this peak dose dyskinesia, so again, if your Parkinson's medications, in a very simple way, if you're trying to stay in this optimal zone of function and your Parkinson's medications bring you through optimal zone and then you go up above your optimal zone, you're kind of over-medicated here, you start having dyskinesia, and then you go back down and your dyskinesias go away, and then they come back when you're back at your peak again. That's called peak dose dyskinesia. And as far as being able to manage that peak dose dyskinesia, there were essentially 3 suggestions. You can obviously reduce the amount of levodopa that you are taking, because it would not take you so far out of your optimal zone, so you wouldn't have that peak outside, ideally outside of your optimal zone. So you can reduce the amount of L-DOPA you're taking. Of course, do that with your physician. The second option that you can use is a drug called amantadine, which is something that's very familiar to me. I feel like that's, at least in the States, it's used quite a bit. But it's the only drug currently approved for its anti-dyskinetic properties, which is anti-dyskinesia. And it does have some support for long-term efficacy, but the longest study that they talked about today was a 12-week study, so about 3 months. So the long-term effects over time are, as far as I know, the literature, I haven't seen that, but it does have some long-term efficacy as far as preventing dyskinesia. And there is apparently a new extended release formulation of amantadine that increased your on time without the troublesome dyskinesia and also reduced the off time. So there are some other newbies on the market that you guys might be interested in paying attention to. Serotonin and glutamate were not found to be effective to treat dyskinesia as of right now with the studies that they presented today. And then the cholergenic drugs, that's a study that's ongoing. They did mention that a drug called L-toprazine reduced the dyskinesia in some patients, but it's not widely trialed quite yet. So those are some newbies to keep your ears perked for on the market. So the third and final way to manage your dyskinesia is using what they call device-aided therapies. Things like deep brain stimulation, especially in the substantia nigra, or what's called the global pallidus internus, or the GPI. DBS in those 2 areas have been shown to be effective for helping with dyskinesia. Also, the levodopa intestinal injections, an infusion where you have it surgically placed so that you have continuous L-DOPA being pumped into your intestines. That has been shown to decrease your off time. And also subcutaneous, which is right under the skin, apomorphine, which is another drug they just insert underneath your skin instead of taking it orally. These are just different places to take your medications, through your stomach or through your intramuscular agents. That drug, apomorphine, also helped increase your on time. So those last 3, deep brain stimulation, intestinal infusions, and then muscle infusions, those 3 are typically not used until your motor fluctuations get more into the severe stage, because they're pretty invasive. You're altering your body, versus these other symptom management by different medications. Those aren't as invasive as they would say. So those are ways to manage the symptoms. And then for those